All right, let's jump right in. Welcome back to The Explainer. Today we're doing a real deep dive into the human brain on psychoactive drugs. We're going to unpack the biological engines of addiction, look at how specific classes of substances actually manipulate our physiology, and frankly, confront the clinical realities of dependence, withdrawal, and treatment. If you're looking for a rigorous, high-yield masterclass on how these drugs literally wire and rewire the body, well, you're in exactly the right place. Okay, let's dive into this by anchoring ourselves to the absolute core of the science. Before we look at any individual drug, we really have to understand the baseline system they're all manipulating, and that is the dopaminergic reward pathway. This is the universal neural circuit driving addiction. Whether we're talking about a stimulant, a depressant, or anything in between, the common denominator connecting all of them is the triggering of dopamine release right here in this specific pathway. So, here is our syllabus for today's explainer. First, we'll cover the brain's reward pathway, then we'll move through nicotine, stimulants, opioids, cannabis, and hallucinogens before bringing it all together with the medical exam angle. Starting right off with Section 1, the brain's reward pathway, basically our universal engine.
As we go through these substance classes, I want you to keep this universal pathway in mind, because addiction across the board is fundamentally connected to how it gets manipulated. Every drug we're going to discuss today essentially attacks, actually scratch that, it hijacks this exact same system, just using different chemical backdoors. It's kind of like hot wiring a car. You know, different thieves might use entirely different tools to break in, but the engine that revs up is always the exact same. So whenever we talk about cravings today, instantly picture this dopamine-driven circuit just firing away in the brain.
Moving right along to Section 2, nicotine, and its remarkably strong physical dependence. Now, nicotine presents us with a fascinating yet incredibly deadly paradox. It acts on nicotinic acetylcholine receptors, which triggers that dopamine release we just talked about. But here's the thing. Compared to other drugs, the subjective effects of nicotine are pretty mild, right? You don't see massive, chaotic behavioral intoxication with someone smoking a cigarette. Yet, it creates an exceptionally strong physical dependence. It's a stealthy stimulant. Because that intense physical craving drives continuous tobacco use, it remains a leading preventable cause of death worldwide.
Now, what's really interesting about this slide is the intense contrast between the severe withdrawal symptoms and the multi-pronged medical treatments we use to fight them. Withdrawal, which means irritability, severe anxiety, and inability to concentrate, increased appetite, and insomnia, typically peaks in just a few days but can drag on for weeks. To combat that, we hit it from 3 angles. First, nicotine replacement therapy. Patches, gums, lozenges. This satisfies the craving while getting rid of the incredibly toxic smoke. Second, we have targeted medications like bupropion and varenicline, which actually blunt the reinforcing effects of the nicotine itself. And third, behavioral support. Things like CBT and quit lines absolutely skyrocket success rates when paired with the medical therapies.
All right, Section 3, stimulants and the inevitable crash. So when we shift gears to major stimulants, we're talking cocaine, amphetamines, meth, we are looking at drugs that violently increase both dopamine and norepinephrine activity. This surge produces immediate, intense euphoria, hyper-alertness, and drops your appetite to zero. But the dark side of this massive neurochemical spike is brutal. Chronic use carries extreme medical risks. We're talking severe cardiovascular events, intense paranoia, and full-blown stimulant-induced psychosis. The body is essentially being pushed way, way past its natural red line.
Section 4, opioids and the extremely high overdose risk.
So the crucial point is understanding exactly how the body rebounds from these vastly different substances. On the left here, when someone comes off stimulants, they experience a crash. It's characterized by profound physiological exhaustion, total fatigue, dysphoria, sleeping all day, eating everything in sight. But look over at the right side. Opioid withdrawal isn't just a crash. It is a severe, systemic physical syndrome. Patients go through intensely unpleasant flu-like symptoms, agonizing muscle aches, severe GI distress, and just profound jumping out of your skin agitation. Medically speaking, they are 2 completely different clinical pictures.
And beyond that horrifying withdrawal, opioids are acting on specific opioid receptors to give pain relief and euphoria. But the stark medical reality we have to talk about is the overdose mechanism itself. Opioids carry an astronomically high risk of death, specifically through respiratory depression. The brain literally forgets to tell the lungs to breathe. And this risk goes completely off the charts with variable street purity or if the user makes the fatal mistake of combining opioids with other depressant drugs.
Because the dependence and the lethality are just so severe,
our medical treatments have to be incredibly structured. For long-term maintenance, the gold standard is opioid agonist or partial agonist therapy, so evidence-supported medications like methadone and buprenorphine. But in a literal life-or-death emergency, where someone is actively experiencing respiratory depression from an overdose, the immediate absolute go-to intervention is naloxone to acutely reverse it.
Section 5. Cannabis and hallucinogens.
And this brilliantly illustrates a total shift in how these drugs operate. The physiological dependence here is generally much lower than what we see with alcohol or opioids, but the psychiatric risks are highly specific. Look at cannabis. It acts on the endocannabinoid, or CB1 system, giving you relaxation and altered perception. But the key risks, especially with heavy use starting in adolescence, include amotivational patterns and a definitively increased risk of psychosis in vulnerable people. Then you have hallucinogens like LSD or psilocybin, and dissociatives like PCP. They trigger profound alterations in how you perceive reality. The physical addiction might be low, but the psychiatric risks include terrifying bad trips, lingering flashbacks, and, particularly with higher doses of dissociatives, severe aggression and detachment from reality.
Okay, before we hit our final section, I want to pose a question to you, sort of a clinical mystery to test what we've covered. Why can alcohol withdrawal actually be fatal, whereas opioid withdrawal, which, as we discussed, feels intensely, horribly unpleasant, is rarely fatal on its own? Just let that hang in the air for a second.
Which brings us right to the climax of our explainer. Section 6, the medical exam angle.
If you're studying this from a medical or clinical perspective, precision is literally everything. You have to understand the exact boundaries between three things: tolerance, which is needing more of the drug to get the same effect; active intoxication, the real-time clinical signs of the drug in the system; and physical withdrawal, how the body violently reacts when the drug is taken away. If you blur those lines in a medical evaluation, you are going to make critical errors.
And that brings us to the answer to our question, which cements one of the most vital clinical distinctions you can learn. On the left, withdrawing from alcohol and sometimes benzodiazepines can be incredibly dangerous, even fatal. Why? Because the nervous system becomes dangerously overactive and you can literally seize to death. On the right, contrast that with opioid withdrawal. Is it excruciating? Yes. The flu-like symptoms and GI distress are agonizing for the patient, but the withdrawal syndrome itself is rarely fatal on its own. It's a massive classic exam angle that completely changes how you triage a patient.
Well, we've covered a ton of ground today, from the stealthy nature of nicotine all the way to the harsh realities of opioid respiratory depression and clinical withdrawal. But I want to leave you with this one final, really provocative thought. If addiction across all of these vastly different substances fundamentally stems from hijacking that universal dopaminergic reward pathway, how does medical science evolve to treat the addiction without completely destroying our incredibly human natural ability to feel reward in everyday life? It's kind of the ultimate puzzle in neuropharmacology, right? Thank you so much for joining me for this explainer. Keep seeking those answers, and I'll see you next time.